Welcome back to Navigating Cancer. I'm Dr. Joey Bennett along with Wendy Hall, and we are joined tonight with a special guest, Todd Sandlin. Todd is the nuclear medical technologist at PET-CT of Florida. He does the PET scans, and I bet many of you out there have had a PET scan and have probably met Todd and may recognize him. We've been going over some of the imaging studies we use in cancer, and we're now kind of getting into talking about PET scans.
I have a question, though.
Please.
So who orders these, and then how does that happen? What do they order them for?
Wendy, any physician can order a PET scan. You have to have a prescription, a signed prescription to get one done. But they're done for colon, they're done for lung cancer, breast cancer, many different reasons. Most any kind of cancer, even skin cancer with melanoma. But you do have to have a prescription to get one done. Now, there are different reasons to have one done. It can be used to diagnose cancer. It can be used for staging. That would be once they know there's a cancer, they want to do a whole body scan to make sure there's no other cancer that they're not aware of, that they don't know about yet before they begin treatment. And then there's a restaging visit. And that's after they've been to RBOI or after they've had chemotherapy, and they want to see what they've accomplished with the treatment of the patient and see if the cancer is diminished.
And it's really helped us, you know, from a standpoint of staging patients. We are having a phenomenon that's developing that's called stage migration, and it's because we're seeing things on these PET scans that we never saw before. And we would have someone come in with a lung cancer or so, and on the CT scan we didn't see any lymph nodes that looked funny, but on a PET scan all of a sudden here's this tiny little lymph node that's just lighting up. All of a sudden that person that we may have called a stage 1 10 years ago automatically just turned into a stage 3. And those patients are actually doing better. So what's happening is you're seeing the stage 3s and 2s getting better and better results because we're finding them and we know what to do. And the stage 1s are still doing great. So I mean,
the wonderful thing about a PET scan is sometimes the incidental findings. They may be there knowing that they have a lung nodule and they're there with lung as the reason that they're there for the PET scan. We may see something else in their body where the cancer is already metastasized, and we see something early, and they can get treatment for it very early.
And another thing that that Todd and I have experienced in the past before is I would send someone in who had breast cancer or lung cancer to get a scan, and everything looks perfectly fine in the primary location, and all of a sudden here's a little spot down in the colon that's lighting up.
And saves their life.
Lo and behold, you find this thing that you did not think was there, you send them to a surgeon, and all of a sudden here's a test that has literally saved somebody's life because they probably would not have gone and had a colonoscopy or something else done. So the test provides a lot of benefit to us. Behind us on the screen, what you see is the PET scanner. This is the one that is actually in Beverly Hills at PET-CT of Florida. And kind of tell us what we're looking at.
Well, this is the end of the PET scanner, and that's actually a patient in there. Whenever they're loaded, of course, the table is down lower in this area, and they're loaded onto the scanner head first for most scans. And at the very beginning of the scan, the patient goes in and out at the very beginning, and that's the CT portion of the exam. After that, then they go all the way through the scanner. In fact, they're looking at the ceiling out the other end, so it's not confining, it's not closed in the back, it's open all the way through. And that's when the PET scan starts, and they come back through the machine in usually 6 increments of 4 minutes each, depending on the patient's height. The total scan lasts 28 minutes, and then they're all finished.
And I mean, I think that what you notice, for those of you who have had CT scans before, this looks like a CT scanner in some ways, but much larger, and I think a little bit deeper. The tunnel's a little bit deeper there, but again, on the back side of this scanner, it is open. If people are claustrophobic, there are things we can do
What we recommend is when we're scheduling patients, and when they call the day before, Carol, our office manager, she calls the day before to give complete instructions. We ask if you have the tendency to be claustrophobic. And goodness knows I know that's real. I do not diminish that feeling whatsoever. But if you do have that tendency, we ask the ordering physician to give them an oral medication to take, and I'll tell them when to take it when they get there so that it's just right when they need it. And usually that relaxes them perfect.
I never had one of these, so what would they be telling me? What would I expect if this was my first time?
The patient, is there a slide for the patient preparation?
We can go to the next slide, please.
Okay, this is the preparation, and I am the technologist. I'm not the ordering physician, so I would kind of treat you as if you were a patient, and I'll tell you exactly how we would do it. Carol would call the day before, or Mary Jane, and they would call, and they would tell you the instructions to prepare for the scan. The first instruction would be to be on a low-carb diet, because carbohydrates turn into sugar, and we want your body to be replete of sugar as much as it can be, because we want to get a good scan. So 12 hours before the scan, you would have no or low carbs. That means starchy foods. You don't want to eat a lot of pasta, bread, anything like that. And then for 6 hours before the scan, we want you to be NPO, which is without food or drink, except for water. You can have water, and you can take your oral medication if you are prescribed oral medications. That's not a problem. One of the differences is if you are an insulin dependent, a diabetic patient that does take insulin, we would ask that you take the insulin at least 4 hours before the scan so it doesn't interfere with the scan. And it's cold in our facility usually, because we do have x-ray tubes and they have to be kept cool with the electronics. So we ask that you wear warm, loose-fitting clothes. For goodness sakes, don't wear snaps down the middle of your, a snap-on shirt or anything like that.
Clothes on during
Most of the time, we can scan people with their clothes on. They don't have to change into a gown unless they've got something like snaps going down the middle.
I'd be wearing sweats, man.
Yeah. That's stay warm, absolutely.
The whole procedure takes about an hour and a half, so you have to allot time for it. When you leave, you don't need a driver. You can drive yourself. You're not medicated as to where you can't function and drive, so that's not a problem. But to get back to if you were my patient and you came in, the first thing you would do is you would check in with the counter and fill out a little paperwork. That's the normal part. And one thing that is important, and I don't know if other scans are this way as well, but you do have to have a photo ID for this scan, because it's a federal law that we cannot inject you unless you have a photo ID with you. And some people will come without that, and we have to send them back. But, so we check you in, and then after Carol gets all your paperwork done, as a technologist, I'll come out front and I'll bring you to the back. And that's called our prep room. In the prep room, the first thing I want to do is establish a rapport with the patient, because when people find out they have cancer or they're scared that they may have cancer, I think it's most important that I get a rapport with the person. I kind of have to judge whether they're scared or whether they're mad about cancer or where they're at with their cancer. So I kind of adjust that and determine that. And then I take a good history. I need to know where they're at, whether they're being diagnosed, whether they're being staged or restaged, whether they know they have cancer or whether the doctor thinks they have cancer. I have to judge all that ahead of time, because I don't want to be the first one to tell them they have cancer if they don't know it yet. So a lot of times I have to establish that. After I get a good history from the patient, the first thing we do is we check their blood glucose level, their sugar level. That has to be within somewhat of a normal range. And as we continue in the next segment, I'll describe the rest of what we do.
Because it is a test that's looking for sugar, so if all of a sudden your sugar was way too high, the test is not accurate.
Right.
So we'll be right back, finish this discussion, and show you some pictures.